Hi, this is Dr. Shubham Arora and today we will be discussing about chronic osteomyelitis. Let's start with an X-ray AP view. What we can see here are dense sclerotic bony fragments, which is the sequestrum, surrounded by lucencies in proximal diaphysis with marked thickening of adjacent cortex, that is involucrum, with lucent cortical defect in distal diaphysis, also called cloaca. Now, before heading to the other investigations, let's see some pathogenesis. Most commonly, the infection reaches the bone via hematogenous route, causing localized inflammatory reaction at the hairpin loop of the metaphyseal vessels, which can cause localized edema and increase in intramedullary pressure, precipitating infarction, therefore resulting in active hyperemia causing focal osteolysis and osteoporosis. Inflammatory process then reaches to subperiosteal space, lifting the periosteum and also causing loss of blood supply, causing necrosis. Both cortical and medullary infarct is responsible for sequestrum formation. Now coming to computer tomography in short axis, we can appreciate the findings of X-ray better, like involucrum, sequestrum and cloaca, and also in coronal section. In MRI, T2 weighted imaging and T1 fat cell with contrast are the go-to sequences where we can see the cloaca, the cortical abscess, which are T2 hyperintense and T2 hypointense sequestrum. The adjacent soft tissue also shows abscess, which is T2 hyperintense. In post-contrast imaging sections, we can see hypointense marrow with peripheral hyperintensity, which is suggestive of medullary abscess. Now be ready to click a screenshot of the MRI imaging findings in tabulated form of chronic osteomyelitis. Thank you.